Hi, welcome to another short video on clinical tips with Dr. Jin Kim. In this video, we will be watching a implant surgery in the upper right quadrant, placing two molar size implants, having to replace that single molar that's periodontally unsound. It will require a simultaneous sinus graft, and this is a case that was done in a live surgery training program sponsored by the World Academy of Ultrasonic Piezoelectric Bone Surgery in Saigon, Vietnam recently. I am Dr. Jin Kim. I'm a board certified specialist in periodontics with locations in Southern California. This is a program that has been going on for quite some time. This one was in March of 2025 in Ho Chi Minh City, the old Saigon. It was run together with my good friend and colleague, Professor Dong Sok Son from Korea, Dr. Eric Park, the sinus master from the United States, Grace Kim from Australia, and Dr. Joan Kim, oral surgeon from the United States. The case was a very beaten up periodontal case that required a lot of implant reconstruction. In fact, this patient went through quite a bit at the program that we ran, but this video will focus on the upper right area. The surgery was actually carried on by Dr. Emanual Kim, a very talented clinician from Australia. My wife, Connie Choi, and I have been involved in this case, and this is the wonderful group of clinicians that came from all over, from Australia, from the United States, a couple from Canada, and from Japan. So here is the treatment plan. We're using the FDI numerical system 1516 in the United States. This would be the equivalent of number 2 and 3, I believe, upper right posterior, 2 implants, removing that single standing hopeless molar. This is what the workup shows. We are going to be placing the 2 implants. The width of the sinus was adequate, but the height obviously required some augmentation. So 5 millimeter by 11 and 10, and with careful angulations and so forth, we figured that a sinus lift was clearly necessary. So that is the proposed implant position and trajectory. We will be able to get good stability because roughly 50% of the implant will be sitting in the native bone, and also we wanted to lift a significant amount of the floor and to augment the area with bone material. The patient was obviously somebody who had advanced periodontal disease. Soft tissue was adequately thick, and we're going to fully utilize the keratinized tissue on the edentulous ridge by utilizing a lingualized crystal incision rather than doing a standard mid-crystal. We wanted to maximize. We'll go into the flap design in slightly more detail in a minute, but here is where the tooth was removed and the incision is now extended posteriorly to that molar. The idea is to pick up some keratinized tissue, which is also thick by nature, and to use that abundance of tissue to our advantage to be able to successfully pull off a one-stage surgical protocol, and that is with the healing abutments. We can see the bone volume towards the posterior aspect of the socket, which really isn't going to help the cause, so that's going to be reduced to allow for better flap maneuver. We're going to be utilizing a technique called replaceable bony window technique, which became popularized by our good friend Professor Son. It's interesting to note that technique was published in 2014. A more recent article in 2022, there was a systemic meta-analysis of the so-called bone lid technique, variations of this time, and the literature review was quite generous in concluding that this proposes very minimal complications and is a very predictable method. So that's very good news because we in our small community with Professor Son and colleagues have been using this technique for the past decade or more. Now this is typical of what happens. As we had noticed in the pre-operative CT analysis, bone was very dense. There was no sign of any vessels, so it was going to be relatively safe in that regard. But with any sinus lift, sinus window approach, tearing of the membrane is frequently encountered, and this was no exception. When you go through very dense and thick bone with piezoelectric surgery device, as you can see in this image, putting a slant to it to make it replaceable, and the geometry has to be good, then tear is many times inevitable. To be frank, in my personal frank and honest opinion, I would encounter a perforation anywhere between 10 to 30% of my surgery in routine practice. Now, one thing we have to be extremely cautious is once the tear happens, it doesn't take a whole lot for it to keep enlarging as the membrane, the tension is really what we're fighting against. So the strategy really is to reduce the tension, and that is simply to enlarge the window opening. Now, this becomes a little more tricky because we might end up in challenges of the window being closed, but there are ways to get around. So here we did indeed extend the window to the periphery, and by carefully maneuvering the Schneiderian membrane to the point where the initial perforated area does not have any lateral tension and some relaxation, then naturally the perforation becomes small, and this is a key to how we manage this. My good colleague Eric Park and I have recently published this article in the International Journal for Future Dentistry. It's a management strategy and different scenarios as to how we can close these windows perforations and truly move on with the surgical therapy. So here's a QR code. You can go to ResearchGate and download this article in the entirety. But here is a section of some diagrams describing various strategies that we can use in a practical sense. So there we have it. The window was open, perforation was there, but nonetheless we were able to manage it quite successfully. And then we used collagen dressing to seal up the perforation, platelet-rich fibrin or concentrated growth factor, PRF, CGF, we tend to use those terms interchangeably, and that was placed into the sinus to get up the graft material, and you already see here the image of how the implants are placed in the desired positions simultaneously. This view clearly shows that the replaceable bone window, despite having a very unusual shape due to the perforation, is still manageable, and we're able to put that window back in the position and be able to proceed with the one-stage surgery and flap closure. Just a little note about the angulation trajectory of the implant. This gentleman had a very unusual occlusion, so thinking ahead for the restorative phase, we did have to angulate the implants fairly facially within limits, and was quite workable. But when you do the sinus design of the window, right? If you're cutting this way, you're going to hit the flat. So after extraction, you kind of open the window like that way. Very good initial torque stability in the trajectory that we desire. What is also to note here is the implants are being placed at least 2, if not 3 millimeters subcrestally. We did have the luxury of the bone volume there, so that was feasible. These implants are Biotem, a great manufacturer from Korea, who are the sponsors of the WAUPS life surgery program. And here is the before and the after of how the soft tissue was managed with the healing abutments intact. You can notice in the surgical finish, where the sutures are placed, we have abundance of keratinized tissue on the facial, immediate facial of those implants, which also assures us a very deep vestibule to be able to fully function without restrictions. And posterior to the most distal implant, we also see that the retromolar pad, which was trimmed, the bone was trimmed to be able to close, has abundance of keratinized tissue, which is exactly what we desire. I'm going to quickly review the flap design in this unusual but quite commonly encountered case. We can clearly see the ridge atrophy due to disuse, but also mainly due to periodontal disease. The remaining tooth is clearly visible with a lot of calculus around it and the characteristic moat defect that we see in advanced periodontitis. This is where we would expect the soft tissue to be a sort of a rendition of how that is. Now, a flap design has to accomplish three goals. We have to access the site. Here, we have to be able to place the implant, but also make a window. So the window has to be quite, significantly superior. So that is a consideration. We have to distribute or redistribute tissue types. In this case, we're talking about keratinized tissue and so on. So this is an important factor that we have to factor into the picture. Here, the pre-op image clearly shows the mucogingival junction. Where the missing tooth was, there was a ridge defect. The ridge was compromised in height and width due to the bone volume. But there is a pattern of soft tissue that follows that. The soft tissue, the mucogingival junction follows that, and that means the keratinized tissue is somewhat deficient right at the ridge crest where we desire the implant to be. And when we see that yellow zone where the second implant was going to be, immediately facial to that, we have a very, very thin zone or thickness of keratinized mucosa, which will be to our challenge. So picture this by having a vertical release incision on the anterior portion, having a lingualized 90-degree incision, followed by a sulcular incision around the tooth to be extracted, and by having a curved distal release, which will look like this. The blue lines indicate the incision lines. The red zone indicates where the flap will be. This flap will be manipulated, and the distal portion where the retromolar pad area usually has abundance of keratinized tissue, but also thickness, meaning we can bring in a lot of underlying connective tissue and the blood supply that it comes with. If we can swing that forward like a pedicle graft, then we are able to give the abundance of the keratinized tissue on the facial aspect. That is exactly how we got this case completed. So good placement, but we are also happy with the soft tissue management. And in order for that physical swinging of the pedicle to happen, that piece of the bone on the retromolar, that peak, sometimes we refer to that as sort of the widow's peak in the periodontal world, that needs to be trimmed and cleaned out. We use a piezoelectric surgery device for that, which is quite an easy step. And as a result, we were able to place the implants in ideal position, one-stage surgical protocol with clean and clearly demarcating sinus lift with the graft material visible. Usually we tend to see the bony window in profile in an image like this, but it's somewhat not very clear because the configuration was odd. And here is a comparison of the before and after pre-planning and the actual execution of the implants. So thank you for watching this really neat case. Here is our group. This is Dr. Emanuel Kim in the middle with all the faculty and instructors. And this was another episode of a surgical case with some clinical tips from board-certified periodontist Jin Kim signing off from Southern California. See you soon on another video. Thank you for watching.